How can biomechanics research advance equity in musculoskeletal healthcare? Arthritis is the most common cause of disability in U.S. adults. Osteoarthritis, the most common type of arthritis, is a painful, progressive, and incurable joint disease that touches everyone, from affected individuals to their family members and caregivers, to the healthcare system, and even the national economy as a whole. For example, in 2013, over $300 billion, or 1% of GDP, were spent on healthcare and earning losses due to arthritis. Luckily, around 100 years ago, total joint replacements were invented, starting with materials like ivory and progressing to the metal and plastic implants that we see today. Joint replacements can restore pain-free mobility and hope for healthy, active aging. Unfortunately, the benefits are not evenly distributed. Doctors recommend joint replacement surgery for Black and brown patients at lower rates than for whites, and typically wait until their disease is more severe. Consequently, Black and brown patients have more complications, poorer pain and functional outcomes, and even higher 30-day mortality rates than their white counterparts. How could this be? Structural racism and implicit bias are significant contributors. To start, most orthopedic surgeons look like the picture on the left, while most patients, especially at institutions like UIC, look more like the pictures on the right. Since surgical decisions are virtually entirely subjective, the process is almost designed to bake in bias on the surgeon side and distrust and fear on the patient side. My goal is to eliminate disparities by replacing subjectivity with objective biomechanical tools to personalize care. Using the same motion analysis technology used in Hollywood for special effects, I work to understand how we can use biomechanics to predict and improve patient-oriented osteoarthritis outcomes, including successful joint replacement, improving physical activity, and preventing falls. For example, I have identified specific gait characteristics that predict the likelihood of a good surgical outcome with high sensitivity and specificity. These same gait characteristics can ultimately be used to inform rehabilitation or even prehabilitation to optimize people for surgery and make a good outcome that much more likely. This will remove subjectivity from the surgical decision-making process and ideally result in more equitable outcomes. Funding this line of research has been my biggest barrier. You may have heard of the so-called Ginther Gap, how Black scientists are persistently less likely to be funded by the NIH, and that topic choice, partially, but not fully, accounts for this gap. I fear that the same factors that affect outcomes for patients also affect my chances of taking this work to the next level. Nevertheless, I persist, and I've been successful in attracting NIH funding for other projects while I keep pushing to achieve these long-term goals. I look forward to my next step, an NIH-funded clinical trial for fall prevention in people undergoing total knee replacement surgery. None of this would be possible without gifted trainees, including an army of undergrads over the years who are members of the communities we serve.